Kia ora koutou. Thank you for letting me share some of the outcomes of our work today. This was funded by a Starship Foundation grant led by the New Zealand Cerebral Palsy Registry. And I'm speaking on behalf of the wider team who completed this work. So Alexander led it, and we had some input from paediatric diploma students, Emily and Samantha, as well as other paediatricians, dental surgeon and respiratory physician, and Marie Blackmore, who was also part of the Telethon Kids Institute in Western Australia, gave us a lot of guidance. So I'm going to talk today on the two projects we had in this work. It was the data linkage study and also our checklist pilot. And first, some background on how we got onto this study. So as you know, I work with the New Zealand Cerebral Palsy Registry, and we did a lot of background work, which I won't go into too much, really to get in a good position to be addressing equity and understanding our obligations for tītiriti. And this happened over a number of years working with external providers and is ongoing. But it meant we were in a position that we felt safe to be sharing data. We also had enough data to report on. So as of the end of last year, we had 1,400 participants. We have a couple of hundred more now. In terms of ethnicity distribution, it's pretty much population matched. And in terms of regional distribution, we're very top heavy to the north. Obviously, where we're based makes a big difference. We do have a range of clinical measures that we look at, which I'm going to discuss today, but just to say probably we're fairly similar to the Australian CP registry, population-based register. However, we're probably a little bit more top-heavy towards GMFCS 4s and 5s, and that may be the bias in which we collect information through the hospital system. So how did we get on to looking at respiratory health? Well, it came from a series of conversations, some with our own experts such as Jane Hamer and others, and talking to paediatricians who are coming to us concerned about children going for surgery when they had poor respiratory health. And we also got in touch with the team from Western Australia, Nuala Gibson and Marie Blackmore, and heard about the work they were doing over there and thought that was something we could replicate here. So when we look in general at the picture of respiratory health for typically developing children, I think none of this information will be new to you. So we know we have large amounts of respiratory related admissions. It's an unjust system here, and in terms of inequity for Māori and Pacifica tamariki, and that deprivation plays a huge part within this. So we know that's happening for our typically developing tamariki, but we had suspected that this was similar pattern would be for the children who have higher complex needs. So in terms of cerebral palsy, respiratory illness is known as the most common cause of mortality, and it does differentially affect those with greater disability. As I said before, a lot of work has been done by the team in Western Australia who have looked at the pathway to respiratory illness, which obviously is very complex. And they've also worked on looking at hospitalisation rates, identifying risk factors, and more recently they came out with a consensus recommendation, which I've shared with you in the handouts. In terms of New Zealand data, there isn't a lot for this population. Just last month, we were able to get this information out from the Child Youth Epidemiology Service for the number of deaths for young people over that 4-year period. I think it was approximately 30. Respiratory disease was coded as the cause of death for nearly 80% of them. So we know this ourselves, it is a big problem. And you can see though that mortality data is really delayed. So it's 5 years behind, which is not great. So we talked to Marie and to find out what work that they did. So they produced this work by doing a large data linkage study looking for what were the risk factors around hospitalisations for young people with CP. And they identified the red flags, so the GMFCS level, having a prior respiratory admission and having prior courses of antibiotics. And they also identified then a range of modifiable risk factors which are mentioned here, and I'm sure some of you will be very aware that these are key to these complex children. From this, the group then developed a respiratory checklist, which is available on their Telethon Western Australia site, where you go through and basically address some of those risk factors. So in terms of looking at swallowing, looking at mealtime respiratory symptoms, reflux, and then just general respiratory symptoms. And it comes up with not a score, but it comes up with advice that actually you have risk factors for respiratory illness and, go and see your pediatrician. But it is supposed to be trying to be a preventative model to alert families and clinicians to some of the key risk factors involved. So Marie Blackmore and her team looked then at using that checklist with a very large cohort of 551 children. And this is a busy table, but basically it's showing the checklist down here and then the GMFCS level and the percentages here of people who fit into each group who marked the self-reported checklist. And just a couple of key points. One is that across the board, nearly 50% had any respiratory symptom at all with meals. So respiratory symptoms with meals are common. So these are gurgly voice, wheeze, cough, sneeze, choke, vomit, or regurgitate. The other thing is that we note that it's very much swayed to GMFCS 4 and 5. Again, not surprising. And the group down the bottom, excuse me, with nil by mouth and or oral intake there, they were the ones they found had the highest respiratory admissions. And again, that's not surprising. But I think there is a take-home message that respiratory symptoms are happening across the board. So subsequently, they developed this consensus document, and I've given it to you not because it's New Zealand specific or it comes with a New Zealand equity lens, because it doesn't, but I feel it is a resource that's valuable because it identifies a whole lot of the really complicated factors that are going on with these children to sort of remind you about what we need to consider and look at. So there's the risk factors here in this preventative model, and then it goes around the different areas. I'll highlight here dental health or oral health, and that's one that we've been looking at particularly and hoping to look at further, as there's some recent papers that have shown this may be a really big impact on respiratory health in this population. It goes through different assessment tools, some of which are not available in all centres, like sleep studies, and others which are more readily available. And then it lists treatment options, and we can see here there's a really big physio recommendation, and this is Nuala is a physio who led this work. So I think this is really powerful, and there's a really big avenue here for physio to step in if they're not already in this space, which I've been hearing that they are already, but I think that's really great that this is advocating the work for the therapist with this group. So what we did then was, with the help of Marie and others, was to do our own data linkage to look at health inequities really in terms of hospitalisations in our population from the register. So we matched the NHI to the Health New Zealand data collections over a 5-year period, and we extracted data from the registry, which then sent to Health New Zealand and was matched with coded information about respiratory hospitalisation. We also looked at antibiotic use, deprivation, ethnicity. We didn't look at mortality, obviously, because the data is very behind, as I mentioned before. So this was a very statistically heavy paper, which Alexander just published last year, but I'll give you the brief overview. So we had 1,200 individuals for data linkage. Mean age was 14. Ethnicity distribution was similar to that of our registry. We did find for this whole cohort of CP that we had a statistical difference in that there were more Māori identified at GMFCS 4 and 5. And just to note, that's not saying that is the case, just for that particular cohort, and there are reasons for that, and probably some bias in our data we have on the register as well. We did also find at base level there was higher levels of social deprivation, and the burden was greatest for Māori tamariki, which we have shown before. So for the results, we found that 27% of our cohort had had a respiratory admission over a 5-year period. The mean admission rate was 2, with interquartile range going from 1 to 5. This table here is just for the group that had admissions. We looked at GMFCS level, And really it's showing, in terms of the odds ratio, it's showing that if your GMFC is 5, you have a nearly 12 times greater chance of admission compared to a level 1, and GMFC is 4, around 4 times greater. When we compared the non-Māori to Māori cohort, there's a 1.5 times greater chance if you're Māori to being getting an admission. That relates to quintiles as well. So if you're living in the highest deprivation, of quintile 5, you've got a over 1.5 chance of more likely to have an admission. And there's a 4.5 times more likely to have an admission if you have had over 2 episodes of antibiotics. So this table here, graph here, shows the incidence of hospital admissions by ethnicity per 100,000 population. So we correlated this data with Department of State's population data for the year and age. So there's a range of colourful lines which I'll talk you through, but the bottom line there that it's pointing to with a red arrow is the European, which shows with Asian it's one of the lowest rates of hospital admissions, and again it's not changing over time over the 5-year period. The blue line there is for New Zealand Māori, which is obviously higher, and also it is the only line that was shown to be increasing admissions over the 5-year period. The light blue line at the top represents MILA, which is Middle Eastern, Latin American and African. Again, very high levels of admission, but also very small groups. We didn't get statistical significance for that group. The green line finally is for Pacifica people, and again a high level, but reassuringly the rates are dropping over time. So in summary, what did we find for this group? So similar to Australia, we've got our red flags, and they were GMFCS 4 and 5, quintile 5, meaning you're living in the areas of greatest deprivation, antibiotic use greater than 2, and also we had the factor of ethnicity. So Māori were significantly higher rates, but this was mainly impacted upon by their severity, and also we found that their rates were increasing over time. And again, of note was the group from Mila, which had high rates but was only a very small part of our cohort, so it does warrant further looking into. I'm not going to present the antibiotic data, but just to say there were the similar red flags. So it was for GMFCS 5, and also Māori had significantly higher rates. How does this compare to Australia? Well, actually, so we're listed there in the top, having had 27% of our cohort with respiratory admissions, and Western Australia had 16%. So it's quite a big difference. The average per person, however, was quite similar. So there may be many reasons for that. Could be that our register, as I said, is quite top heavy in terms of GMFCs 4s and 5s, but still was a startlingly bigger difference, which is probably similar to typically developing children's respiratories input and admissions. So the next part of the study was to trial the respiratory checklist in terms of a preventative model, and Alexander led this work, and we had a range of paediatric diploma students. So Emily was one of them who assisted with this work. And this was to pilot just across the Auckland region clinics. Unfortunately, we had COVID during this time, so it was a very challenging time to be doing this, but most of it was done after obviously all the initial COVID lockdowns, but we did have to do more Zoom and phone use of the checklist than we had originally hoped. We're also going to be doing a prospective data linkage from the participants who did the checklist to look at how, if this preventative checklist did actually predict what was going to happen over the next 12 months in terms of their hospitalisation and prescription respiratory related antibiotic use. So we had 94 participants, which was self-reported by whānau. And there is just a difference about the participants. Mean age was 12. This time there were no differences in GMS distribution for Māori versus non-Māori, although we did have a higher percentage of Māori identifying as EDAX 4 or 5 compared to non-Māori. So what were the outcomes from this? This is the self-reported checklist. So these families said in the last 12 months about 20% had had a respiratory admission and 22% had had over 2 courses of antibiotics. And then I'll just go around all the different sections of the checklist. So in terms of swallowing, we found high rates of choking on saliva with eating. 20% had an NG or peak use. In terms of reflux, again, 25% had a history of reflux, 20% regurgitating after meals. About a quarter had mealtime respiratory symptoms, and overall another quarter had just general respiratory symptoms at any time. We had also added in looking at oral health factors, and we found that overall 50% of the cohort had identified toothache in the last 3 months and 20% had bleeding gums, which is a really high rate, much higher than what was reported in the New Zealand Oral Health Survey of around 2010. So the highest prevalence again was for GMFCS 4 and 5 and EDAX 4 and 5. And a lot of the analysis is still going on here, but we did find that there was a link between those that reported with poor oral health and overall admission rates and antibiotic use. So what are our next steps? Well, I've really just put a few quotes here, and this is from Nuala Gibson's paper, but I think you can probably see as well, with such a complex problem, there's actually large scope really for hopefully improving identification of many of those modifiable risk factors around respiratory health. And it's the hope that respiratory review with these children becomes routine, it's coordinated, and it's multidisciplinary. And we hope that obviously by reducing admissions, you can not only reduce costs, but it's that really big health-related quality of life by starting to do more preventative strategies. So for us, we're just coming to the end of this project, and we're really looking for next steps in terms of funding, really, about where we could help and address some of the issues that were identified. And so at the moment, we're just trying to reach out to people to find out what's happening in the community in terms of respiratory care and management, including in the special schools and at hospitals and also out in the community. And then we're looking to different funding organisations to see if we can possibly support more funding to trial some projects. So we've already submitted some funding grants to look at oral health outcomes, and these are around data linkage work to try and look what that is in children with CP. And we have thoughts around looking further at the respiratory checklist to make this more available and used in a clinic situation. We want to understand more what are the experiences of whānau around risk eating, being told you're nil by mouth, respiratory health, and all the complicated factors. So we have put in some grants to try and do some hui and co-design sessions facilitated by others around this. And then there's a whole lot of other factors here we've listed. So it's around education, it's looking at what's currently happening in terms of data linkage perhaps to some of the services that are being delivered, looking at those modifiable risk factors that are on that document more carefully. And finally, different community strategies, so particularly around oral health, but really wanting a model that's whānau empowered, as there are things that they can do in the home that can help with this preventative and surveillance-based model. Okay, I'm back. Thank you. Thank you for putting up with my scratchy voice today. Sorry I'm not there in person, but I did want to acknowledge all the participants we have on the registry, because without them we are unable to do these de-identified sort of data linkages to get really a big picture overview. We hope that information can be used better for advocacy and for services to help start delivering different services or guide what changes they want. Also want to thank some really key physios who are out there who do an amazing job helping notify families around New Zealand about the registry. And I've given you all this information sheet so you can continue to do so. And if others are interested, please contact us. Thank you.